Thank you again. This is the title of the talk that was transcatheter mitral valve replacement, but after some emails with Professor Antoine, we decided to change, to keep the title, but give some reflections. So first I will start with a brief comment to the standard surgical talk that Professor Guevara gave us. That was really nice talk, very illustrative. But we have to keep some things in mind and important messages. Valvular heart disease will become epidemic in the forthcoming years. Our population better treated, so they live longer. Cardiovascular events and prevention, it's improved and by our treatment, so patients with cardiomyopathies live longer, and this mitral and aortic valves and all that stuff will appear because our patients will live longer. So you have to think that the prevalence will increase in a very exponential manner, above all in patients older, above 75-year-olds. And you have to think that mitral valve disease will be present at least in 50% of patients with cardiomyopathies that are not very normal, good candidates for surgery. Another important point is that almost half of the patients that are referred with severe mitral regurgitation does not receive surgery. There's this is motivated by several reasons, but one of the reasons, of course, are because patients are old, and some of patients have comorbidities, and of course as well the LV dysfunction. That is something that surgeons usually they don't like to operate on because of the LV dysfunction, because it's associated with poor outcomes of the patients. And if we see, this is the proportion of patients receiving surgery in a large cohort of a surgical cohort. In patients with DMR, that is the surgery is the best, and I can be totally agree with Professor Guevara in that. Only 52% of patients receive surgery, so there's still 40-something% of patients not receiving surgery that might receive any other treatment. And it's even more important in those patients with functional mitral regurgitation. These usually are heart failure patients that only receive medical therapy, and there's a huge opportunity, a huge room for improvement in the treatment of these patients. Importantly, in patients with DMR, now that, as I told you, the population is increasing in age, so now we have patients above 75-year-old, 80-year-old that are fit, and they have mitral valve disease and they need some treatment. And if you can observe here, results of the surgery in this older population sometimes is not is related to a higher mortality, because usually mortality is very low in low risk population, but with increasing age mortality is increasing, and for repair or replacement mortality, 30-day mortality may be around between 6 and 13%. That may be high and higher than transcatheter therapies. On top of that, patients older are frail, and frailty has always been associated with a poor surgical outcome. So it's something apart from age. We have to evaluate frailty of our patients and decide what is the better treatment. Regarding functional mitral regurgitation, there's some clear messages. Surgery is not always the best option for a functional mitral regurgitation. First, in patients with advanced heart failure and mitral regurgitation, of course, mitral valve surgery, in this case is annuloplasty, has never been proved to increase survival or freedom from transplant. So this is something that the heart failure teams, they are very clear on that, and they usually don't send patients for surgery. And in the right panel, you have this this paper that is in patients with significant mitral regurgitation at the time of coronary bypass. It has been published a couple of years ago in New England Journal of Medicine. Adding an annuloplasty to these patients does not improve survival, but increase neurological events. And if we, on top of that, recurrence in functional mitral regurgitation, even with modern techniques of annuloplasty, above all in patients with ischemic functional mitral regurgitation, is high and increases with time. This is a 2-year outcome of this significant ischemic mitral regurgitation, and at 2 years, adding a mitral valve repair to the coronary bypass does not produce any clinical improvement, does not induce better LV remodeling, but increases the neurological dysfunction at 2 years. So we have to have this in mind when we are dealing with our patients. Talking about the paper Professor showed before, we have to read the small letter of this paper, because you can have in mind that replacement is better than repair for this kind of patients with severe ischemic MR, but really this is not true, because this is driven by the high recurrence rate in the repair group. At 1 year, 32% of moderate to severe recurrence, but at 2 years, almost 50% of the patient has recurrence. So I think this is not comparable. I mean, you cannot drive the conclusion that replacement is better because you have a high recurrence. So probably it's not comparable to groups. And when you have a failing surgical range, sometimes it's difficult to diagnose. You need transesophageal echo. You have to be very expert, because sometimes what you think is a small jet is difficult, because there have some artifacts due to the ring, and you cannot see a huge jet penetrating in the LA. But if you see a huge jet just in the voxel of the ring, probably this is a significant MR. Sometimes it's difficult to diagnose, and we have to pay attention. So these results in these trials of functional regurgitation have impacted the guidelines. So this is the first time that we have seen in the last years not an increase in the surgical indication, but a reduction on surgical indications. If you see in 2012, you should, it was reasonable to add a mitral technique when you were operating on coronary bypass of patients if you have significant mitral regurgitation, but this has been taken now out of this recommendation, because I showed you that there's no clinical improvement increase in neurological events. And in those patients with functional mitral regurgitation and not severely depressed LV function, more than 30%, that still are symptomatic, now in this year they have added that patients should have low surgical risk to be operated on. That means that usually these patients, if you have some moderate risks on some factors that might affect the surgical events, you don't have to think much on surgery. So there's a movement when we get the data on surgery and functional mitral regurgitation with these randomized trials that are, like restricting a little bit the surgery in this field. Mitral regurgitation is very important in patients with heart failure. And these are not typical surgical candidates. It's common and it's associated with a poor prognosis. These patients, at 5 years, all of them almost have been admitted to the hospital with heart failure or have died. So this is it's a high-risk population. And this population is having a lot of readmissions, that this increases a lot of the cost of the care. So we have to think about strategies. Of course, surgery is one of them, but but there's a huge, large unmet need with the MR treatment, because there are a lot of gaps that surgery has produced that we have to fill with new technology. But as a professor said before, mitral is not aortic valve. Aortic valve is a simple valve. Mitral valve is a really complex valve. And we have a lot of targets to work on if we want to create devices to try to correct mitral regurgitation. Now this is one just a simple slide of the number of devices that we are that has been developed by industry, and more to come. There's a lot of them that this demonstrates that the mitral valve is quite complex, because there's no single device that solves our problems. We have a lot of targets. Mitral valve disease is a complex disease, so we need a lot of devices. No one is ideal, but we have to probably mix some of them to achieve optimal results with the transcatheter therapies. So I will review a little bit the new devices for mitral valve repair, and then we will move a little bit in the mitral valve replacement transcatheter area. First device I want to show you is the Cardiovan. Cardiovan is the first clinically used direct annuloplasty device that reproduces an incomplete surgical ring. The axis is transeptal, so this is quite important for us. And this is an incomplete band that you see is coming from transeptal and is fixated to the all the posterior part of the annulus by some anchors, some screws that are implanted in the annulus. You need a CT scan pre-planning to decide if the patient is a good candidate. You have to select the length of the band. You have to know the anatomics of the AV junction to see if the circumflex is far, if you can implant all the screws around the annulus. So you start to implant and to move your band through the annulus, and at the end what you are going to get is an incomplete ring from commissure to commissure that at some point can be shortening. And this shortening is what reduces the annular dimensions and reduces the MR. This is now commercially available, probably in top countries in Europe like Germany. There have been a lot of starting to have the more experience, but probably even in Spain we can do it from next year. And this is something that is important because as it said before, MitraClip is a leaflet device, although it has some effect in the annulus as well. In functional patients, MitraClip reduces the annulus. And in DMR patients, the annulus does not increase with time, at least at 5 years of follow-up in Everest trial. So, but we need, of course, we need something to act in the annulus. This is what we will, what I think that maybe is the future now. So when you have this, you implant it, you see this is the fluoro, how you see all the screws in the posterior annulus, and then you cinch it with the spool mechanism, and it's shortening the septolateral dimension, as you can observe in the slide. And when you are cinching between 20 and 40%, you can obtain a significant reduction on the MR. This is what has been published, what has been demonstrated with this device in a low number of patients so far, is that we reduce the septolateral dimension, that is quite important, and we reduce the degree of MR at a level similar that obtained with MitraClip. There's some follow-up at 6 months with this device with persistent reduction in the MR and some reduction in the LV volumes, but not significant. One important thing of this device, it does not preclude of using another device. You can use it combined with MitraClip, can be a dock system to implant in a valve in the future, so this can be appealing characteristics. Next device that we're going to talk is an indirect annuloplasty device, that is a carillon. This is implanted through the coronary sinus, and it's a metal piece that will produce a shortening of the coronary sinus that is in quite contact with the annulus, and this will reduce the annulus and the mitral regurgitation. What has been proved that this device reduces the regurgitant volume and the effective orifice area, and makes some improvement in the clinical parameters of the patients and the quality of life. But the implant success is not very high, it's only 62%, and we have two problems. First, that the coronary sinus is not always related to the mitral valve annulus. Sometimes you implant the device and you don't have a good annular reduction. And there's an important relationship between the coronary sinus and the circumflex. So sometimes you can damage the circumflex, you have to look for that. Next device is MitraLink. That this is a system that implants a couple of pledgets in the mitral annulus and produces local remodeling. This is done through retrograde approach, through the aorta to the ventricle. Some wires, radiofrequency wires, penetrate the annulus, and then you implant the pledgets. And when you cinch the pledgets, it reduces the annulus. What has been proved is that this not reduce very much the mitral regurgitation, because it's just local remodeling of the annulus, but has some impact in the reduction in the LV volumes and in the mitral valve annulus parameters. So that's what we have so far. It has been tried in more than 70 patients, but probably this is not a device that we will use in the future. Next device we have, it's as Professor said before, neocord implant is a relevant part now of the treatment of DMR patients in surgery, but we can implant it now in a minimal invasive fashion in a transapical approach. This is the first trial published. you need usually more than 2 or 3 cords, neocords, to be implanted to achieve, at least in this early series, not a very high reduction in the mitral regurgitation in 30 days. But with increasing experience, and it's very important as well, the type of pathology that you are treatment, when you increase your speeding, when you use multiple cords, and when you don't treat very complex pathology, just P2 prolapses, results can be very, very good, and can be very durable as well if the annulus is not dilated. That is at least what is the rationale of this technique. However, on the other hand, if you have complex pathology, bileaflet prolapse, anterior leaflet prolapse, this is the results are worse than observed when the anatomy is easier to treat. Another device that you will hear in the forthcoming years and months, because it has been acquired by an important company that is Edwards, is the Pascal. That is a kind of mitral clip by Edwards. It's called Pascal. It's same philosophy, but with a difference that you have a spacer between these clip arms. Technical is the same for implant. It has been published in the first 23 patients with interesting MR reduction and improvement in the walking distance, but only a 78% of device success. That is far from what we achieve now with mitral clip, that is 95-98% of success. So probably there's a learning curve as well with this device, but you have to bear in mind that if Edwards owned this device, it's appealing that they have as well Cardioband, and so maybe you can combine these two devices to achieve an optimal MR reduction. But of course, these repair devices does not stop here. There will be different coming. We can in the future implant cords by transeptal approach. That I think, in my view, is the optimal approach for all the mitral valve therapies. We have new devices for treating degenerative MR, and we have new rings that we will see in the future, apart from Cardioband, that we can use to obtain better results or more durable results of our repair techniques. When we move to the mitral valve replacement by a transcatheter therapy, first we have to stop a little bit in the valve-in-valve and valve-in-ring procedures, that what we are doing now in most of cases of mitral valve replacement. It has been recently published, a large series in the literature that is almost 250 patients, most of them treated with the SAPIEN XT or the SAPIEN 3, and most of cases done by transapical approach. What we have seen is that there's a good correction of mitral regurgitation that is better in the patients with a failed bioprosthesis than a failing ring. So failing ring is probably a different scenario. And complications and mortality is higher in patients treated with a valve-in ring. And if we follow up these patients, we have seen that implant the valve in a ring is an independent predictor of mortality in the long term. And this is probably due to more complications during procedure, more mortality during the procedure, more paravalvular leak than in the failed bioprosthesis, because rings are not always flexible and cannot always be modified by the implant of a circular valve. And probably because the ring patients are worse patients with worse LV function and with more comorbidities, and this impacts as well the mortality. We have to bear this in mind, but it's something feasible. I have done it a couple of times, and the results are really, really good. And what is more interesting, what will increase our portfolio for treating transcatheterly the mitral valve, is the development of mitral valve prostheses. Logically, there's no ideal mitral valve prosthesis, because there are more than 30 companies that are developing its own valve. So first, what all of the people, most of people, interventional cardiologists think when we are talking about mitral clip or valves or rings, they are very fond, very keen on the valves, because there's a huge promise that mitral valve replacement with transcatheter valves will become something like TAVI, something predictable, easy, everyone can do it, fluoro-guided, you don't have to work with echo people, you can do it by your own. This is the promises, but probably reality is not in that way so far, because we have to face a lot of challenges with these new therapies. First is the delivery system. So far, the delivery system is very huge, very large catheters, 32, 36, 35 French, and this is important to increase the access complications. The ideal delivery system should be transeptal if we want to minimize all the access complications. We have problem with fixation, and you will see in a while that have a lot of different fixation types because there's no one ideal. All of them have problems. We have problems that we don't know what to do with the leaks, because valves, transcatheter valves in mitral position are under a high closing pressures, because systolic pressure during the LV contraction it's very high, so paravalvular leaks might represent a problem and may have more impact in the clinical of the patients. We don't know a lot of hemodynamics of this valve so far. We have the risk of left ventricular outflow tract obstruction, as with the mitral valve repair replacement in surgical candidates, but this is more important because it's very difficult to correct. We have to know more about the residual MR and the gradients, and of course we need more about durability. We don't know what happens with the stents in this zone that is movement constantly. So we might have some stent fracture, we might have some leaflet degeneration, we could even induce erosion and native issue where we implant the valve, so we still don't know. Of course, the security, what will happen with these patients in the future, and we don't know yet very well how to select patients. We have a very safe technique, that is repair, percutaneous repair, and this is more aggressive, so which patients should be in every technique. As I told you before, fixation varies from valve to valve. We have Tendyne, that we will talk in a while about this valve, that has an apical tether, that is what fixes the valve to the ventricle. We have the Navigate, that have some annular winglets that impacts the valve in the annulars. We have the Tiara, that have some anchors, subannular anchors, 2 in the anterior trigons and 1 in the posterior leaflet that anchors the valve. We have the Intrepid, that is a Medtronic valve, that have some these barbs and this radial force that anchors the valve in the annulus. We have the Cardiac-Q, interesting valve from Edwards, that mainly implanted transeptal, that have some anchors that anchors the valve in a supraannular position to the leaflets. And we have the High Life, that is another concept. First you have to implant a ring, subvalvular ring, and then this will serve as a dock system to implant the real valve, and you can do it either transapical or transeptally. So still a lot of things that we don't know what's better. For sure, CT scan is mandatory when you plan to implant a transcatheter valve, because you have to know exactly the size of and the shape of the annulus when you want to implant the valve, and you have to predict the most feared complication, that is the left ventricular outflow obstruction. You can predict it and the neo LVOT that you will gonna have and how this behave, but a lot of factors can impact this, and all of them has to be analyzed before deciding that the patient is candidate for a transcatheter replacement. You see that there's more than 30 valves now in the market that are developing and trying to treat patients, but this is the one that has more patients, and we are going to discuss a little bit on them. This is a table when you compare more or less all the valves, and I will leave you with this presentation. There's difference in the asymmetric valve, because Tendyne and Tiara are D-shaped, has an outer stent that is D-shaped, that is this is the shape of the mitral annulus. The other ones are circular because provide better hemodynamics, but probably the asymmetrical annular valves has better coverage for paravalvular leaks. Almost all of them are working for a transeptal approach. That probably will be the default in the future. And all of them are created in pericardial valve. Tendyne is in porcine, the other one is in bovine pericardial. Just a quick view of some of the valves, and we will stop a little bit in Tendyne. That is the valve that we have more data. We have the Edwards Cardiac-Q, that is I showed you before. This is the sheath that is deflectable, and it's like a Edwards TAVI, but through the transeptal. The valve is anchored to the annulus with these anchors, and you have this skirt as well that serve us to minimize the paravalvular leaks. There's some program of development of the valve. It has a stop due to some problems, that is resuming again the problem. Still with very low numbers of patients implanted, important 30-day mortality, that this might be related to the patient characteristics, but as well as the procedure itself. Then we have the tiara. This is as you see in the top picture, it has a D shape, has three anchors, two in the anterior trigons and one in the posterior leaflet to be anchor. We have some experience in the long term that is well treated, but still some unsuccessful implants and high 30-day mortality. This is a very interesting valve. It's the Casson valve. That this is fully transeptal, so it's very appealing. And you have a nitinol frame that is implanted first in a subannular position, and in this nitinol frame you implant the valve in a second position. And all the time both the frame and the valve are fully retrievable, so it's quite safe. It's started this development program, the Prelude trial, starting and the Interlude trial, starting to recruit patients, and as in the previous valve, still some technical problems with mortality and with paravalvular leaks, and still is not fully developed. High Life, as I told you before, and you see in the picture, is a dual mechanism valve. You have to implant first percutaneously a subannular ring, a plastic ring, and in this plastic ring you implant your valve, either transapically or transeptally. It has been reported some problems because always the ring not always is perfectly implanted, and if it's not correctly implanted and you implant the valve inside, probably you have some dislodgement of the valve, so it's still an ongoing technology. And we have the two main valves nowadays, probably this will change in the future, are the Intrepid valve that is owned by Medtronic and the Tendyne valve that is owned by Abbott. This is the Intrepid valve that is outer stent, as you observe in the bottom part, with that is circular as well, that has a lot of radial force and have the barbs that is fixing the valve to the annulus. It's implanted transapically right now, and inside the valve you have another circular valve that has the leaflets that is circular because it produces better hemodynamics. So it has been recently presented, the Intrepid program, with the first 50 cases implanted and with the follow-up. As you can observe, this is the successful implantation was achieved in 98% of the patients. That this is the higher for all the programs published so far in transcatheter valves, and the procedure is not very long, so it seems like quite predictable. But as you can observe in the bottom part, sometimes we need intra-aortic balloon pump and sometimes we need ECMO support. That is quite relevant because one thing that is important is that during the implantation of these transcatheter valves, all of them, sometimes we have some hemodynamic disturbances that can impact the clinical events of these patients. So we have to be aware of this. The summary of the first 50 patients treated is a 30-day mortality of 14%, that is not very high, 1 year survival of 77%, and with no MR, no or mild MR in all survivors, and with 80% of patients in class 1 or 2 in the follow-up. So it's a quite pushing for these valves that so far has not very good results, but this is, I think it's quite okay. So it's so okay that it has been started and it has been the first patient recruited. The Apollo trial is a comparison between Medtronic Intrepid valve and standard surgical replacement. And we will see for both DMR and FMR, and we will see in the future main primary endpoint is a non-inferiority, and we will see in the future if this can compete with the surgical valve. So it is a very, very aggressive and very appealing program that hopefully we can have some answers in the future. And for me, the best balance in the valves, transcatheter valve so far, is this valve that is owned by Abbott, is the Tendyne valve. And it has as well two parts. It has an outer stent that is D-shaped to accommodate the D-shape of the standard annulus of the mitral anatomy, and has an inner stent that is circular that provides better hemodynamics and with a huge orifice. We have several sizes to accommodate to different types of annulus, and the fixation is a tether to the apex. This is how we implant it. You get that. So far, we get a transapical access, and then you make sure that you are not entrapping a corda. So once you are in the LA, you deploy the LA part of the valve, and you are deploying the stent frame, and finally you fix it in the apex with this tether device that serves at the same time as a hemostatic paddle. This is one case. You look at this. This is a severe DMR patient with probably, it can be treated with mitral clip that we have now, but look at this extra movement of the leaflets. Probably the result won't be very good in the follow-up. So they decide to go for the valve. Look, although it's a complex anatomy, you can see in the bottom part the good result with the Tendyne valve. But the valve can be used as well for treating functional mitral regurgitation patients. As you can observe here, is a functional mitral regurgitation patient with a central jet. This can be treated with mitral clip, probably with good result, but in this case they decided to go for the Tendyne valve, and you can see the impressive result they obtained with no residual MR, no complications, and a very good result. This is how we see the Tendyne valve from the standard and fast view of the mitral valve, with this atrial flange that is against the paravalvular leaks. And this is how we see it in the follow-up with the CT scan. Valve is tethered to the apex, and it's weirdly sit in the atrial size of the annulus, and look how the valve respects the outflow tract that is here. It's completely free, so this provides good hemodynamics. This is the valve with more implants so far, more than 100 cases in several countries. We have the global feasibility trial that included the first 30 patients, but we have now in this trial more than 75 patients. This is inclusion criteria, and this is the exclusion criteria. That is very important, because so far the main one of the main shortcomings of the transcatheter valves is that there is a high screening failure. A lot of patients are screened for the implant of the valve, but 60-70% are dismissed because they don't fulfill the criteria. And look that in this valve they didn't go for very large, very dilated, and very poor ventricles. This is a baseline characteristics, similar probably to mitral clip, even a little bit better than mitral clip populations. We have an 80% of success. We have some problems during the implant, but the valve is fully retrievable, so you can detect it and you can retrieve the valve and nothing happened. We have some obstruction of the outflow tract. Sometimes the valve did not sit properly, or what I told you before, sometimes patients develop hemodynamic instability. That's something that we have to have in mind to select the patients. We have some adverse events, of course. We have to keep in mind that we will have some paravalvular leaks, then we have some thrombosis, so we have to keep this in mind for the future. What has been published is the MR is drastically reduced, and we have some inverse remodeling. But we have now as well 30 patients with 1 year follow-up. Mortality is 16%.
We are far behind the schedule.
Okay, I'm finishing. We have some adverse events, but you see the reduction in the mitral regurgitation is impressive. We don't have much remodeling, and one thing that we have seen importantly is that 1 year LV function is declined. That we have to analyze this because we don't know if it's for the valve or for the type of patients. Functional class improve and quality of life, and this is a mortality. Interestingly, what I want to show is the mortality is still high for all these valves. If you summary of these valves, mortality at 30 days is 23% still implanting these valves. So you cut the MR, but sometimes you cut the patient as well. And this is important if you compare it with the 30-day rolling cohort of the mitral clip co-op trial that is 0% mortality at 30 days. So you have to balance this. So we have some shortcomings, that is the hemodynamic instability, still high 30-day mortality, the obstruction of the outflow tract, high screening failure, and no long-term data. So we have this still to wait. But we will have in the future, and I will leave these slides for your presentation, is that we have to combine all this to treat properly the patient with MR with transcatheter therapies, in FMR or in DMR. And this is my conclusions, that what I said, transcatheter repair has appeared to cover a large unmet need regarding MR treatment. It's a complement to surgery in high-risk patients. Mitral with the wider experience, new repair devices will refine the results. TM valves will increase the possibility of treatment, and Tendyne probably is the best result so far. And this is for the surgeon. This is the trial of repair versus replacement in ischemic functional mitral regurgitation. As you observe, there's no difference in clinical events. The red line is the replacement, but there are only 120 patients in every group. Probably we have 1,000 patients in every group. There will be a difference in mortality, so repair better in mortality probably. And look at the inverse remodeling in patients with a successful repair. It's 20 milliliters of difference in the LV volumes, and there's same volumes for the repair that recur that the valve. So I'm not sure that we should replace all these valves. Probably a successful repair is better. And this is my last slide. Thank you so much.